Good evening, and thank you for joining us for this webinar, which is the second in a series of 4 that we're conducting on the topic of co-occurring substance use and mental health conditions, funded by the Central and Eastern Sydney Primary Health Network. My name is Catherine Mills, and I'm an Associate Professor and Director of Treatment Research for the Centre of Research Excellence in Mental Health and Substance Use at the University of New South Wales. And I have the pleasure of facilitating this presentation, which will be given by Dr. Christina Morell. I'd like to begin, though, by acknowledging the traditional owners of the land on which we meet, the Bidjigal and Gadigal people, and to pay my respects to elders both past and present, and extend that respect to any Aboriginal and Torres Strait Islander peoples that we might have with us today. As I mentioned, we have an exciting series of 4 webinars. The first one, a couple of weeks ago, provided an overview of co-occurring substance use and mental health conditions. And leading on from that, this one is focused more on how to identify mental health disorders and related conditions among people with alcohol and other drug use disorders. And then we have the 2 remaining webinars. The next one will focus more on the management and treatment of co-occurring conditions. And then the final one in December will look at managing physical health of people with co-occurring disorders. And you can register for any of these by visiting the Central and Eastern Sydney Primary Health Network website, which the link is on the slide there. And if you happen to miss any of these webinars or would like to watch them again, you can also download them from the comorbidity.edu.au website there, along with the handouts. And on that site, you'll also find a number of other presentations, webinars that have been given on substance use or mental health, and also relating to their prevention and treatment. So just before we begin, I just wanted to draw your attention to the Q&A button, which is on your screen. Please feel free to click on that button at any time during the presentation and write comments or questions. We'll have about 10 minutes at the end of Christina's presentation to go through them and to have some discussion. And if you experience any technical difficulties at all during the presentation, you can call the technical support line there, which is on the screen, and quote those details, or alternatively, you can go to the online chat. But I've also put this information in the chat box so that you can go back to it at any time during the presentation if you need to. And lastly, as I mentioned, we will be recording this webinar for download later. So it is my pleasure to introduce Dr. Christina Morell, who is a research fellow at the Centre of Research Excellence in Mental Health and Substance Use at the University of New South Wales. And her research aims to improve our understanding of co-occurring mental and substance use disorders and improve our treatment responses, particularly in relation to complex populations that often have multiple chronic conditions and require many sort of health and social service responses. Christina's work is built on strong collaborations with clinicians, consumers, carers, and other key stakeholders, and a big part of her work is also related to translating research findings into evidence-based resources for clinicians as well as the community. Thank you, Chris.
Thank you, Kath. And thanks so much for joining us for this webinar today. So as Kath said, the focus of tonight's webinar is on identifying mental disorders and related conditions among patients with alcohol and other drug conditions. So although, as Kath mentioned, the webinar tonight is the second in a series of 4 webinars on addressing co-occurring substance use and mental disorders, you don't need to have attended all 4. Our intention is really to provide enough information that each of these can stand alone. So if you're just interested in learning or finding out a bit more about how to identify comorbidity, for example, you can just come along to tonight's webinar. So there will be a bit of overlap between each topic. And as with the first webinar that we presented a couple of weeks ago, a lot of the material I'll be talking about today will be drawing directly on the second edition of the National Comorbidity Guidelines, which are more formally known as Guidelines on the Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings. And these guidelines were launched late last year, and they were developed as part of a broader program of work which is being conducted through the CREMS program at the National Drug and Alcohol Research Centre. If you're interested in this resource, it can be accessed here. And if you're worried that you can't click on these links during the live recording of the webinar, don't worry, we'll be making this presentation available to download as a handout at the end of the webinar. So all of these links that I'll be referring to throughout the talk tonight will be live or clickable a bit later on. So before we get started, I wanted to quickly run through the learning outcomes of tonight's webinar. And these are to have an understanding of how, when and why to conduct assessments with an improved awareness of structured and unstructured assessment techniques, have a better understanding of the differences between substance-induced and independent mental health disorders, and have a better understanding of a coordinated approach to managing comorbidity and how to involve multiple services to deliver coordinated care. So in terms of what we'll be covering in tonight's webinar, I'm going to start with a brief overview of what we know about comorbidity, followed by how we go about identifying comorbidity. And here I'll talk more in depth about screening, assessment, and the case formulation process, including informal and standardized screening and assessment techniques. I'll then talk a bit about the importance of engaging with other service types and providers to meet various patient or clients' needs as identified. So I'd also like to start tonight's webinar by introducing you all to James. James is a 51-year-old male who's employed full-time as an accountant. He presented to his GP asking for a script for oxycodone for back pain, which he said he initially injured playing squash. And of course, this is just one way in which a person with comorbidity might present to services. There are many different presentations, but if somebody with James's presentation does attend a service, what are the next steps? How is his comorbidity identified, if at all? And I'd just like you to try and keep these few brief facts that I've told you about James in your minds as we progress. I'll be coming back to James as we progress through the process of screening, assessment, and case formulation. So our first challenge is to consider James's presenting issues, and in doing so, consider them within the broader context of what we know about comorbidity. And before doing that, I wanted to clarify what we mean by the term comorbidity. So broadly defined, comorbidity refers to the co-occurrence, either lifetime or current, of two or more disorders. And our focus here today is on the co-occurrence of alcohol or other drug, or AOD, and mental health disorders or conditions. There are, of course, lots of different types of comorbidity, including other AOD use disorders, including tobacco, physical health conditions such as cirrhosis, hepatitis, heart disease and diabetes, intellectual and learning disabilities, cognitive impairment, and chronic pain. The co-occurrence of one or more AOD use disorders with one or more mental health conditions is often referred to as dual diagnosis, but this term is often misleading because many clients present with a range of co-occurring conditions of varying severity. We also know that comorbidity is common. Mental and substance use disorders are two of Australia's most common and burdensome health conditions, and they affect around 1 in 5 Australian adults each year. They frequently co-occur. So it's estimated that around 1 in 3 Australians with a substance use disorder also have a mental health disorder, but this rate can be as high as around 75% among people who are seeking treatment. In terms of the most common mental health conditions that we see to co-occur with substance use disorders, these are typically the same as those that we see in the general population, which are anxiety and depression, PTSD and personality disorders, but we also see elevated rates of bipolar disorder, psychosis, ADHD, OCD, and eating disorders. And the fact that these disorders co-occur is problematic because once they're established, each serves to maintain and exacerbate the other. There are also many people who experience symptoms of the disorders but don't necessarily meet the criteria for a diagnosis of a disorder. And this means that a lot of people can have their lives significantly disrupted by symptoms of their mental health disorders, but without meeting the diagnostic criteria for a mental health disorder, they tend to fly under the radar of a lot of services. So rather than thinking about mental health as merely the presence or the absence of a disorder, it can be quite useful to think of mental health conditions existing on a continuum from mild symptoms such as mild depression on one end to severe disorders like schizophrenia or psychotic suicidal depression on the other end. And with the development of new versions of classification systems like the DSM-5 and the ICD-11, there's been more of a move towards dimensional rather than categorical views of disorders. The prevalence of mental health disorders can also vary between substances, but there's been little research conducted which compares the rates of mental health disorders across different types of AOD use disorders. So there's not a lot of information available that can help guide health practitioners in this sense. So substance use among those with mental health disorders tends to mirror the general population trends in terms of availability and fashion. So I'm going to launch a poll here and ask you what you think the three most commonly used substances are in the general population. So do you think that they're cannabis? And you can choose, you can choose three. You can actually choose more than three, but just choose three if you don't mind. Cannabis, non-prescription opioids, tobacco, heroin, alcohol or illicit substances, cocaine or methamphetamine. The three most commonly used substances in the general population. So I'll leave this poll open for maybe another 10 seconds. Just a few more votes coming in. Okay, in 5 more seconds. Cool. Okay, that's actually really interesting. Okay, so if you answered tobacco, alcohol, and illicit substances, which a lot of people did, you're right. So in the general population, alcohol and tobacco are the most commonly used substances, and a smaller proportion of the population uses illicit substances. And of the illicit substances, the most commonly used are cannabis, and this is followed by smaller proportions who use methamphetamines, ecstasy, cocaine, hallucinogens, inhalants, heroin, synthetic cannabinoids, ketamine, new and emerging psychoactive substances, and GHB. And then again, smaller proportions use non-prescription pharmaceuticals, including analgesics, tranquilizers, steroids, methadone or buprenorphine, and other opiates. But when do we need to become concerned about a person's use? Like, should we be responding to any use, or is it only when a person is dependent on substances that we need to be thinking about intervention? So not everybody who uses will become dependent, and the evidence indicates that the most addictive substance is tobacco, with up to an estimated 2/3 of people going on to develop dependence after first using it. And then this is followed by cocaine, heroin, alcohol, and cannabis, with up to 1/5 of users developing dependence. But it's really important to note that while many people drink or use at high levels without meeting criteria for a disorder, they may nonetheless be at risk of harm. In general, few people who experience these conditions access treatment, in part because they have difficulty accessing services, and in part because of the stigma that they're often faced with when they do. So an estimated 1 in 10 people with a substance use disorder alone seek treatment, but when you have substance use, mood, and anxiety, this rate increases to around 70 to 80%, which indicates that mental health, or the complexities that accompany comorbidity, might be a driver into treatment. But even among those who do manage to access treatment, there's often an incredibly lengthy delay between the time they start to develop symptoms and when they eventually make treatment contact. So the evidence tells us that the median delay among people with alcohol use disorders who eventually make treatment contact in Australia is 18 years. And a large part of the problem in people being able to access treatment is that our clinical services, and particularly those for comorbidity, have traditionally adopted a siloed approach in which mental and substance use disorders are treated separately. And as a consequence, people can be bounced between mental health and AOD services with little continuity or continuation of care, and a lot of people end up falling between the cracks in the healthcare system. People with comorbidity often have difficulty navigating their way through available services. These can be incredibly difficult to access, even when you're well, with multiple entry points and options of treatment pathways, agencies, and healthcare providers. And often by the time somebody with these disorders is ready to access treatment, they've been experiencing symptoms for many years and can be really challenging to be bounced and referred between services like a roundabout, or to be faced with a closed door. So comorbidity is a problem because not only do people with comorbidity experience symptoms of their mental health and substance use disorders, but they also have complex presentations, and this can complicate their treatment and recovery. And research has shown that people with mental or substance use disorders die 20 to 30 years earlier than the general population and spend the last 10 years of life living with disabling chronic illnesses. And in fact, comorbidity has been identified by the Mental Health Commission as one of health's most significant challenges. So the key points so far, comorbidity is common and it can complicate a person's treatment and recovery. Once comorbidity has been established, it's most likely that the relationship between disorders is one of mutual influence, and a number of barriers make it difficult for people with comorbidity to receive effective treatment. So I'm going to move on to the next topic of our webinar, which is how can we identify comorbidity? So in general, the identification can be tricky because despite high rates of mental health conditions, the detection and treatment of these coexisting problems is usually quite low. And that's why it's quite important to screen clients systematically as part of routine clinical care, as part of the case formulation process. Awareness of co-occurring problems will assist with the management of more complex presentations and treatment planning. And identification doesn't necessarily mean that the healthcare worker has to personally treat the difficulty of the client's experiencing, but they do need to consider the impact of these needs and manage them accordingly, and then engage with other services where necessary. And of course, to identify problems accurately, there might be a need to involve professionals who are trained and experienced in differential diagnosis, and screening can help identify the potential need for formal psychiatric assessment. And multiple assessments conducted throughout treatment can take into account changes in symptoms over time and then be fed back into the assessment process. Fed back into the treatment process. Clinicians are also encouraged to become familiar with the DSM-5, in particular its uses, limitations, and recommendations regarding differential diagnosis or which symptoms are attributable to which disorders. It can also be quite useful to be aware of the different signs of disorders, so meaning what's objectively visible about the clients, for example, sweating, as well as symptoms of disorders or what the client describes, such as feeling sad. So screening is the first process. Screening is a process of identifying possible cases of co-occurring mental health conditions. It's not a diagnostic process, so it can't establish whether a disorder exists, but it can be useful in identifying symptoms which are typical of a disorder and then highlight the need for further assessment. Ideally, it should be conducted after a 2 to 4 week stabilisation period, but in practice, this can be very difficult to achieve within treatment settings. So workers really need to be aware of the potential for false positives, which can occur if clients are screened during periods of acute intoxication or withdrawal. And to avoid the possibility of misdiagnosis or false positives, multiple assessments should be conducted over time. Assessment involves a detailed investigation of a person's mental health and should be an ongoing process that takes into account changes in mental health symptoms throughout treatment. Assessment also involves case formulation and treatment planning. The process of case formulation involves gathering information regarding factors which may be relevant to treatment planning, and then formulating a hypothesis of how all of these factors fit together to form the current presentation of the client's symptoms. So after developing a case formulation, the health worker should be aware of what problems exist, how they developed, and how they're maintained, and as well as that, other aspects of the client's presentation, their current situation, and the interaction between these different factors and problems. And then this information is the first step to devising and then later revising the client's treatment plan. So the primary goal of any service should be to improve the client or patient's quality of life. But of course, in order to do so effectively, healthcare workers must take into account the broad range of issues that people may present with. So there's no standardized approach to case formulation, but it's really important that a range of different dimensions are considered using a combination of informal and standardized assessment techniques. So I'll first talk about informal assessment. And this should be in the form of a semi-structured interview in a non-judgmental, empathetic, private, and confidential environment. So if there are any limits to confidentiality, so for example, with coerced clients or patients, or in a juvenile setting, these should be explained. Components that should be covered in the informal assessment include the mental state, source of referral and current healthcare providers, presenting issues, AOD use history, the current situation, personal, medical and family history, trauma history, psychiatric history, risk assessment, criminal history, strengths and weaknesses, and readiness to change. So I'll go through each of these in a little bit more detail. So a crucial component of the assessment process is an evaluation of the client's mental state and their presentation. The mental state examination isn't, or it shouldn't really consist of a series of direct questions, but should be based on an overall evaluation of the client or the patient during assessment, or preferably a number of assessments. and a record of the mental state examination should be completed after rather than during conversations with the client. And as well as noting any abnormal or unusual client behaviours, is also quite good practice to record normal behaviours. So for example, no speech disturbances noted, no unusual thought content noted. And I put a link here to a form that might be useful in gathering or guiding note-taking for the mental state examination. So assessment and mental state should include appearance, behaviour, speech and language, mood and affect, thought content, perception, cognition, and insight and judgment. But all of these factors, just to note, can be affected by intoxication or withdrawal from substances. So in terms of the client or patient's appearance, consider how they look. What's their posture like, their grooming, their clothing, their nutritional status? Is there any evidence of AOD use? How are they behaving? Consider their motor activity, take note of any abnormal movements and any bizarre, odd, or unpredictable actions. How are they reacting to the current situation and to you? Do they seem angry or hostile, uncooperative, withdrawn, overfamiliar, fearful, guarded, or hypervigilant? How are they talking? Is their speech rate rapid and uninterruptible or slow? Take note of their tone and volume, their speech quality, and anything else unusual about the client's speech. How are they expressing themselves? Does their communication seem to reflect incoherent or illogical thinking with disorganized or senseless speech? Are ideas connected, or is there any evidence of derailment or tangentiality? Does the client seem to have an absence or excess of thought and rate of production? And is there evidence of any thought blocking? How do they describe their mood? And what do you notice about their emotional state or affect? Do they seem depressed, flat, restricted, tearful, or down? Are they anxious, agitated, distressed, or fearful? Do they seem to be irritable or hostile? Are they labile or rapidly changing in mood? Does their emotional state seem inconsistent with the content and context? So for instance, are they laughing when they're talking about their mother's death? Are they high or elevated, excessively happy or animated? What are they thinking about? Are they having delusional thoughts? Are they preoccupied with paranoid, depressive, anxious, or obsessive thoughts? Are they thinking of harming themselves or others? Is the client experiencing any misinterpretations of sensory stimuli? So do they report auditory, visual, olfactory, or somatic hallucinations? And if so, are they likely to act on them? Do you observe the client responding to unheard sounds, voices, or unseen people or objects? Are there any other perceptual disturbances such as derealization, depersonalization, or heightened or dulled perception? Take note of the client's level of consciousness. Are they alert to time, place, and person? Are they attentive during the interview? Are they drowsy, stuporous, or distracted? Does their attention seem to fluctuate, or do they seem confused? Is their concentration impaired? So for example, can they count backwards from 100, or can they say the months of the year backwards? Does the client know who he or she is, who you are, where they are, why they're seeing you, what day it is, the date, month, and year? Can they remember why they're with you, what they had for breakfast, and what they did around this time last year? Can they recall recent events or do simple calculations? Do they have any insight into their current situation? And how aware are they of what others might consider to be their current difficulty? Are they aware of any symptoms that might seem weird, bizarre, or strange? And are they able to make judgments about their situation? So James's mental state examination appeared to be quite unremarkable. He was well groomed and presented with no evidence of AOD use. His behaviour was normal. He appeared cooperative with normal speech patterns and clear, logical language. His mood appeared quite normal. He didn't report any perceptual disturbances and seemed alert to time and place. Now I'm going to move on to other factors that we would need to consider as part of the case formulation process. So clients can have various sources of referral into treatment, such as through their GPs, their families or friends, corrective services. In general, the most common source of referral is self-referral. In addition to identifying the source of referral, it's also important to identify all healthcare providers who are currently involved in the person's care. So for example, counsellors, psychiatrists, prescribers, GPs, probation or community offender service officers, caseworkers and social workers. And consistent with a coordinated approach to client care and with the client's permission, liaise with these providers regarding treatment to ensure continuity of care. And I'll talk a bit more about that towards the end of the talk. Ascertain what the client perceives to be their biggest issue and the reasons why they're in treatment. This is usually broader than the AOD or mental health in isolation. So for example, psychological, social, health, legal, accommodation, financial issues. And it's also important to gain an understanding of the range of substances which are currently being used, the quantity, frequency, duration and circumstances of use, previous AOD-related problems, risk behaviours relating to use, and the previous treatment or attempts to change and why these were unsuccessful or successful. Clinicians should also try and gain an understanding of the development of the client's AOD use over time, including any periods of abstinence and how these were supported. Also ask about the use of any non-traditional or new psychoactive substances, which are substances produced to mimic the effects of illegal drugs, and these can be referred to by a range of different names, including legal highs, herbal highs, research chemicals, analogues, and synthetics, and more information about these can be found through the Drug Trends Monitoring Program. Some healthcare workers can be reluctant to address their client or patients about the AOD use for several reasons, and some of these include concern that asking about AOD use will disrupt and potentially damage rapport, the belief that clients or patients won't disclose their use anyway, so there's no real point asking about it, a lack of knowledge and or confidence in how to respond if AOD use is reported, assumptions that certain clients or patients are not using AOD, and a lack of recognition of the signs and symptoms of AOD use. But if clients ask directly about their AOD use in a non-judgmental way, with open-ended questions within a therapeutic relationship, they're more likely to talk about their use. So health workers can access information to help them respond to a client who reports problems with substance use, for example, Health Pathways if you're in the CESPIN region, and the Australian Drug Information Network or ADN for information on services. And some examples of ways to ask about AOD use include asking open-ended, non-judgmental questions such as, can you tell me about your alcohol or drug use in the last month? It can also be useful to ask the client to describe a normal day in order to try to help them evaluate the ways in which their AOD use affects their health, relationships, legality and livelihood, like their finances and work. And more detail about the typical day can be found in the hyperlink, which I've put on the bottom of the screen there. Some examples of ways not to ask about AOD use include making judgmental statements such as, don't you know the harm you're doing to yourself? Or making assumptions about the person in front of you, such as, you don't use substances, do you? In both of these examples, if the client or patient does use AOD or is considering whether or not to disclose any AOD use, an approach like this is likely to make them shut down or not reveal any details about their AOD use. It's also important to remember that anybody can develop a disorder, and there's often a lack of recognition of substance use and mental health disorders because of assumptions about what a person with these disorders might look like. So when James was eventually asked about his AOD use, he reported that until recently, he had been drinking 6 to 8 bottles of beer and half a bottle of wine every night, drinking several gin and tonics each weekend. Until this recent visit with his GP, James had not been directly asked about his substance use, which he thinks is because he always turned up to sessions in a suit and tie. When asked about his alcohol use in the past, he's always said that he drinks socially, and no further questions have ever been asked about the nature and quantity of his drinking. Recently, he's been taking oxycodone to help him cope with his back injury. It can also be helpful to ask the client about their current accommodation, their living arrangements, their children, family and friends, social and other support networks, their significant relationships, physical health, study, work commitments, legal and financial issues. Exploring and discussing the client's background can help both the client and health worker understand the beginnings of the AOD use and mental health symptoms, as well as the impact on the client's life. So ask about the family context, including any family history of AOD use and mental health disorders, child and adolescent experiences, school experiences such as academic performance, social experiences or bullying, traumatic experiences, work history, leisure pursuits and personal interests, financial and housing information, sexual or marital adjustment, legal issues and illegal behaviour, medical history including current and past medications, psychiatric medications, and current and past pharmacological or psychological treatment. It's also important to identify whether the client has experienced any traumatic events in their life. So traumatic events don't refer to any events the person's found upsetting, but they're events where the individual perceived their own or someone else's life or physical integrity to be at risk. So the trauma may be a one-off event, or it may have occurred over a period of time. And I'll go into a bit more detail about trauma given its importance, and it's an area that clinicians often have difficulty with. So a history of trauma exposure may be integrally linked with the person's current AOD use. A number of people with AOD use disorders who have experienced trauma describe their use as an attempt to self-medicate the thoughts and feelings they have had since the trauma. The presence of a trauma history also indicates that further investigation is needed to determine whether the person may have symptoms of PTSD. While identification of past trauma is important, questioning needs to be sensitive and shouldn't be pursued if the client doesn't wish to discuss it. So in some circumstances, it might be better to raise the issue of trauma several weeks after the initial assessment interview once the client feels safer and has developed a therapeutic relationship with the health worker. Before conducting trauma assessments, workers should seek training and supervision in dealing with trauma responses. Also, some health workers may be reluctant to discuss trauma with clients because of events that have happened in their own lives. This is completely normal, and workers really need to feel that they can seek assistance from their colleagues and not feel like they're being forced to conduct trauma assessments if they're not comfortable doing so. So before questioning the client, healthcare workers should seek the client's permission to ask about exposure to traumatic events and advise the client that they don't have to talk about these experiences or provide any detail if they don't want to, and clearly communicate the reasons for asking about past trauma. So it might not be obvious to the client that their current situation may be related to their past. For example, clearly explaining to the client that the questions relating to trauma will help contextualize their drug use, which will also help gain a better understanding of the interplay between AOD use and trauma symptoms. Advise the client that talking about traumatic events can be distressing. So even clients who want to talk about their trauma history may underestimate the level of emotion that's involved. Studies have found that while some people may become upset when talking about these events, talking about the trauma doesn't overwhelm or re-traumatize the majority of people. And on the contrary, a lot of people describe the process as a positive experience. Advise the client of any restrictions on confidentiality. So for example, in relation to the mandatory reporting of children at risk or serious indictable offences. When broaching the subject of trauma, ask the client if they've ever experienced any traumatic events, such as witnessing or experiencing car accidents or other types of accidents, natural disasters, war, adult or childhood physical or sexual assault, or having been threatened. So reliable reporting of events is best obtained by asking about specific event types. And underreporting of exposure tends to happen when people are only asked broad questions such as, have you ever experienced a traumatic event? Standardized screening tools such as the Traumatic Life Events Questionnaire and the Trauma History Questionnaire can be used to assess for a history of trauma exposure. Some clients find it easier to complete a self-report screener than to say aloud to the assessor that they have, for example, been raped. But these types of screeners should always be completed with a clinician present and should never be given to a client to complete at home. Some additional guidelines for discussing trauma include: create a safe, welcoming environment, adopt a non-judgmental attitude, display a comfortable attitude if the client describes their trauma experience, commend the client for having the courage to talk about what's happened, normalize the client's responses to the trauma and validate their experiences, and finally, it's essential that the health worker questioning the client doesn't dig for information that's not forthcoming, because this can result in destabilization. You can also ask whether the client has any current mental health symptoms such as depression, anxiety, or psychosis, whether they've experienced these in the past, and whether they've ever been diagnosed with a mental health disorder. It can be really difficult to differentiate between substance-induced and independent mental health disorders. So symptoms of mood, anxiety, and psychotic disorders can all be induced as a result of AOD use or withdrawal. For example, AOD use and withdrawal can induce symptoms of depression or anxiety. Manic symptoms can be induced by intoxication with stimulants, steroids, or hallucinogens, and psychotic symptoms can be induced by withdrawal from alcohol or intoxication with amphetamines, cocaine, cannabis, or LSD. Other disorders that can result from AOD use include substance-induced delirium, amnestic disorder, dementia, sexual dysfunction, and sleep disorder. So asking about the client's psychiatric history can help identify whether a mental disorder is independent or substance-induced. If the client has experienced mental health symptoms or has been diagnosed with a mental health disorder, you can ask about the timing of these symptoms. So when did they start? Was it prior to the AOD use? Do they only occur when the person is intoxicated or withdrawing? Have symptoms continued, or mental health symptoms continued, even after a period of abstinence of about a month? Do the symptoms change when the client stops using substances? Do they get better, or do they get worse, or do they stay the same? Is there a family history of that particular mental health condition? If symptoms occur only in the context of intoxication or withdrawal, it's likely that they're substance-induced and they'll resolve with a period of abstinence without the need for any direct intervention. But having said that, it's still really important to manage these symptoms to prevent the client from relapsing. But if mental health symptoms started before the onset of substance use, if they persist even during periods of abstinence, or if there's a family history of that particular mental health condition, they might have an independent mental health disorder. It can also be really difficult to distinguish substance-induced psychosis from other psychotic disorders, and if a person is experiencing symptoms of psychosis, it may not be possible to elicit information that will help assess the onset of symptoms, the family history, the AOD use, and so on. But substance-induced symptoms can help differentiate between substance-induced psychosis and independent psychotic disorders. So substance-induced symptoms tend to appear more quickly. They usually last a shorter amount of time, until the effects of the drug wear off, although for some people they can last longer. And visual hallucinations are more common in substance withdrawal and intoxication than in primary psychotic disorders. Stimulant psychosis is more commonly associated with tactile hallucinations or ice bugs. And people experiencing stimulant psychosis may be more agitated, energetic, and physically strong, and also more challenging to control in a safe environment. And they also may be more difficult to calm with sedating or psychiatric medication than independent psychosis. It's really important to assess the risk a client poses to themselves or others in the informal assessment interview and to monitor this throughout treatment. So there are several areas of risk that should be assessed and monitored throughout treatment, including suicidal thoughts, self-harm, domestic violence, both the perpetration and victimization, homicidal thoughts and attempts, and child welfare, as well as the evaluation of safety regarding sexual practices, injecting practices, and other high-risk behaviours. So in any situation where the risk of harm to self or others is perceived to be significant, other services may need to be enlisted, such as police, ambulance, or crisis teams. AOD clients are at high risk of suicide, and the presence of comorbidity further increases this risk. So it's really important to conduct suicide risk assessments in the initial consultation phases and then monitor this risk throughout treatment. To ascertain risk by directly asking about suicidal thoughts, the frequency, intensity, plans and intent, the history of suicidal behaviour and self-harm, current stresses, hopelessness and protective factors, so for example, family, friends and other services. And more information about suicide risk assessments can be found on the hyperlink that I've put on screen there. So discussing suicide with clients is vital, and it does not increase the risk of suicidal behaviour, but sensitive questioning by a worker can be a relief for clients who've been harbouring thoughts of self-harm, and can also be an opportunity to receive the help and support that's needed. So a resource that clinicians might find useful is a Suicide Assessment Kit, or the SAK, which was developed by researchers at the National Drug and Alcohol Research Centre, and I put a link to the SAK on this slide. It has resources for clinicians and for services, and this link also has some useful videos on how to use the suicide risk screener, as well as more information about the resources. I also put some examples of the types of questions that can be used to complete this assessment on this slide, and I won't go through these in detail. There's also guidance available on what could be classified as low, moderate and high risk, as well as some suggested responses on what to do if somebody does screen into these levels of risk. AOD use has also been associated with both the perpetration and victimisation of domestic and family violence. So evidence suggests that up to 80% of women who attend AOD treatment have experienced violence. And although domestic and family violence is commonly characterised as males using violence against females, this is not the only form of family violence. Other relationships can experience family violence, including same-sex, non-spousal, carer and children. The high prevalence of AOD clients who have experienced domestic and family violence really highlights the need for workers to conduct thorough and effective assessments and then respond to the problem. So health workers should also have an understanding of the kind of dynamics and complexities which are involved in domestic and family violence and the reasons why many people remain in violent relationships. And these include fear of further violence, increased danger, loss of life, stalking or abduction, isolation or rejection from family, friends and community, loss of home, income, pets and possessions, or having a reduced standard of living, negative impacts on children such as loss of school, friends, community, relationships with parent or family, grief for loss of partnership, feelings of guilt and self-blame, and fear of losing children or having children removed. So to be aware of current stresses, inquire about past and present criminal behaviour, arrest history, any impending court cases or outstanding warrants, as this information can impact on the client's treatment plan. A client's strengths and weaknesses can usually be figured out from other information that's collected throughout the assessment process. So some examples of strengths might be good social support, high self-esteem and insight, and some weaknesses might be unemployment, risk-taking behaviour, or negative self-image. It can also be helpful to assess how motivated the client is to change their current AOD behaviours, and this involves an exploration of the client's perception of the positive and negative aspects of continued AOD use. So assessing readiness to change is also relevant in assessing motivation to receive treatment for comorbidity. Just because a person has presented for treatment for their AOD use and might be willing to consider reducing their use doesn't necessarily mean that they have the same readiness to receive mental health treatment, or means automatically that they're ready to deal with the trauma-related symptoms that they might have experienced due to abuse they experienced as a child, for example. So the stages of change model, which I've put up here on screen, can be quite useful in assessing motivation to receive treatment for comorbidity. And I won't go through this in detail, and you can read more about it, or you can read more about the model if you're interested in the guidelines I've mentioned before. But in putting this up here, I just wanted to point out that the model has been subject to some criticism because of the distinction and division between stages and the focus on conscious decision-making rather than the involvement of other factors such as unconscious motivations. The Integrated Motivational Assessment Tool, or the IMAT, which is shown here, can be a useful matrix for assessing motivation for both AOD and mental health treatment. So next I'm going to talk a bit about standardised screening and assessment. In addition to the informal assessment process, there are a range of standardised screening and assessment tools, and these can be useful and used to help clinicians gather data on their clients. So these provide a reliable and valid view of the client's difficulties and their current life situation, and when they're conducted appropriately, they can be quite a good way of building rapport. Standardised assessment should be conducted and completed upon entry into and exit from treatment, as well as at follow-up. Test results can provide useful clinical information for both the client and the health worker on the client's case, and as well as an evaluation of how effective treatment has been. So a variety of different tools are used, some of which are empirically established instruments and others are purpose-built, internally designed tools with increased practicality and utility, but they might have unknown validity and reliability. So when conducting standardised assessments, it's really important to provide the client with the reasons for the assessment and the purpose of each instrument. Explain that it's a standard procedure, explain how standardised assessments can be helpful in, and useful in helping clients achieve their goals. So, for example, by providing an objective measure, and provide appropriate and timely feedback of the results of the assessment. Standardised tools cover a range of areas which might be relevant to services with AOD and mental health clients. And some of these require specialist training, or else mislabeling, misinterpretation, or inappropriate use can occur. So some tools are copyright protected and need to be purchased and or require the user to have specific qualifications. Some are self-reporting, meaning they can be completed by the client, and others need to be clinician administered. Another resource which clinicians might find useful is Mark Deedy's 2009 review of screening and assessment tools for use in AOD settings. This includes quite a really good overview of all screening and assessment measures, where they can be accessed, whether there's a cost involved in their use, details of their reliability and validity, as well as their strengths and limitations. And that's free to download. I've put the hyperlink on that slide there. In some AOD use instruments that might be useful include the CAGE questionnaire, which assesses problem drinking, the Michigan Alcohol Screening Test, or the MAST, which assesses lifetime problems with alcohol use, the Drug Abuse Screening Test, the Alcohol Use Disorders Identification Test, or the AUDIT, and the Drug Use Disorders Identification Test, or the DUDIT. The Kansas is a widely used measure, and this assesses need across 22 domains, including accommodation, food, self-care, capacity to look after the home, daytime activities, physical health, psychotic symptoms, mental health and treatment, psychological distress, risk to self and others, AOD use, social relationships, childcare, education, transport, budgeting, and benefits. The short form measure, which is known as the Kansas P, is for clients to self-complete. It's rated on a 3-point scale: no need, met need, or unmet need, and no staff training is required to use it or score it. The Kessler Psychological Distress Scale, or the K10, is a widely used, simple self-report measure of psychological distress, and it can be used to identify those who are in need of further assessment for anxiety and depression. The Australian SciCheck screening tool has been shown to be a valid and useful resource for clinicians. It has 3 sections, which are a general mental health screen, including a history of treatment, a suicide self-harm risk assessment, and the self-reporting questionnaire, or the SRQ, which assesses for current symptoms of depression or anxiety. The SciCheck manual includes training on how to administer, score, and interpret the results of each section, and what steps to take according to the screening results. And more information on the SciCheck screening tool can be found at the link I've put on screen there. The Depression Anxiety Stress Scale, or the DASS, comes in 2 forms: the DASS-21 or the DASS-42, and this measures depression, anxiety, and stress separately, and also taps into a more general dimension of psychological distress. The Primary Care PTSD Screen, or the PC-PTSD, is quite a brief 4-item screen, and it's designed for use in primary care and other medical settings to screen for PTSD. It includes an introductory sentence that cues respondents to traumatic events, but it doesn't include a list of potentially traumatic events. So as I mentioned before, when we were talking about trauma, underreporting can happen when people are only asked broad questions and are not asked about specific event types, which is something to keep in mind if you're thinking about selecting a PTSD screener. The Trauma Screening Questionnaire, or the TSQ, is a 10-item screening tool for PTSD. Respondents who endorse at least 6 items should be assessed for the presence of PTSD. The Psychosis Screener is a clinician-administered interview-style questionnaire rather than self-report, and it uses elements of the Composite International Diagnostic Interview, or the CIDI, to assess for the presence of characteristic psychotic symptoms. The Indigenous Risk Impact Screen, or the IRIS, and this was developed by an expert group of Indigenous and non-Indigenous researchers in Queensland to assist with the early identification of AOD and mental health conditions and mental health risks. It's been shown to be reliable, simple, and effective, and it consists of 13 items which are asked by the clinician, made up of 2 sets of questions. There's an AOD risk component and a mental health and emotional wellbeing risk component. The World Health Organization's developed the Adult ADHD Self-Report Scale, or the ASRS, as a means of assessing symptoms of ADHD in adults. And there's a full version of the scale which contains 18 items and a short screener version which contains 6 items, but the short 6-item version actually has been found to outperform the original 18-item scale. The Eating Disorder Examination, or the EDE, is a diagnostic interview, and this has been modified to reflect current DSM-5 diagnoses. So the EDEQ is a questionnaire form of the EDE, and both are considered to be gold standard measures of eating disorder psychopathology. So as an interview, the EDE is designed to be administered by a clinician, and the developers recommend clinician training to ensure all concepts being assessed are well understood. But the EDEQ is a self-report measure which can be completed individually or with the help of a clinician. And both instruments can be downloaded for free at the website I've put on screen. So following the completion of assessment procedures, it's really important to interpret the results for the client in a way they can understand, so not just giving them numerical test scores. When feeding back assessment results, focus first on the client's strengths, gently and tactfully outline the client's difficulties, focus on the pattern of results rather than just an overall score, and pull the assessment results together and offer hope for the future by discussing a treatment plan. And again, it's important to stress that screening measures are not diagnostic, so it's important not to label a client as having a diagnosis of a disorder unless a comprehensive assessment's been made by a suitably qualified mental health professional. Rather, it's better to focus on the symptoms which are being displayed by the client. And although there was little evidence in James's mental state examination to indicate that he was experiencing symptoms of a mental disorder, during the informal assessment process, he discussed details of depressive symptoms and previous episodes of depression. Over the past several years, he's had 5 separate episodes or 5 separate occasions where he's felt incredibly low. These episodes have increased in intensity, with the last 2 involving suicidal thoughts. James needed to take a significant time off work as sick leave after the last episode. When he was given the DAS-21, he scored high in depression and moderate in anxiety, and this prompted further assessment of his depressive symptoms. His last episode of depression was so severe that he was admitted to a local psychiatric unit. He had high suicidal ideation with a plan and means with which to kill himself. He was prescribed antidepressants that he continues to take, but there was almost a complete reliance on pharmacotherapy in previous episodes. James had a family history of depression. His father and paternal grandfather all experienced severe depression over the course of their lives, and his grandfather committed suicide in his early 60s. James described how he and his previous doctors had accepted a genetic causation of his recurrent depressive illness, without much thought being given to other factors such as his AOD use. So we'll be talking in detail about what to do in terms of management and treatment once comorbidity has been identified in the next webinar, but I really briefly just wanted to mention that once symptoms have been identified, discuss with the client what they can expect to experience in relation to their symptoms if they reduce or stop using substances. So for instance, their symptoms may dissipate or lessen, especially if substance-induced, or they may increase or worsen when they reduce or stop using, especially if they're using to self-medicate. It's also important that clients know that you'll be monitoring these symptoms to determine whether further treatment may be needed. So the key points of identifying comorbidity are, given the high rates of co-occurring mental health conditions among clients of AOD treatment services, it's essential that routine screening and assessment be undertaken for these conditions as part of case formulation. Consider a range of factors in the process of case formulation, so not only AOD and mental health issues, but other factors. And full assessment should ideally take place after a period of abstinence, or at least when the client isn't withdrawing or intoxicated. Conduct multiple assessments throughout treatment as symptoms may change over time, and provide assessment feedback to the client in a positive, easily understood way. For the final chapter in tonight's webinar, I'm going to really quickly talk about coordinated care. So throughout the assessment process, there are various issues that are identified that need to be addressed during the course of treatment. So for example, education and training, family situations, housing, legal issues, employment and physical health. So we really highlight the importance of services and workers developing links with a range of local services and engaging them in clients' treatment where it's appropriate. So in practice, coordinated care should involve the coordinated delivery of individual services across multiple sectors, which is perceived as a seamless service system by clients, which results in overall improved client outcomes. So I'm going to quickly launch another poll here, and oops, sorry about that, just a second. Where's my second poll? Having some polling problems. Okay, I'm not going to be launching another poll. I'm really sorry. I was going to ask everybody, and maybe you can just think about it, what services you would need to bring in to coordinate about James's care. I'm very sorry about that. I was going to ask whether you would bring in a psychologist, a psychiatrist, social welfare services, translation or culture-specific agency, housing, criminal justice, employment services, medical services, mental health, or a general practitioner. So James's GP contacted his psychologist and psychiatrist to devise some treatment options. After presenting various options to James, it was decided that he'd continue with his current antidepressant medication, and this was working pretty well so far. See his psychologist weekly and receive regular ongoing monitoring of his physical health from his GP. Particular attention was paid to his liver function, respiratory health, and blood pressure. So despite a few lapses, James progressed pretty well through treatment. Initially, he had some trouble abstaining from both alcohol and oxycodone, but eventually he stopped drinking and reduced his oxycodone use. In planning his treatment, James had decided that he would take some extended time off work to concentrate on his mental health. So the key points to take from this case study are that people with comorbidity do not necessarily present in any obvious way. There's a high prevalence of older people who have continued to use AOD, and the need for careful history taking regarding AOD use cannot be overemphasized. In some cases, mental health conditions may quickly respond to appropriate treatments, but comorbidity presents a number of challenges, in particular the need to maintain treatment gains over the long term, so over years rather than days, weeks or months. So to give a summary of all the information, and I know I've presented a lot of stuff, very dense, AOD and mental health disorders are common. So it's really important that clients are routinely screened and assessed for comorbidity as part of routine clinical care. Clients with comorbidity often have a variety of other medical, family and social problems, so housing, employment, welfare and legal problems, and it's therefore really important to consider a range of aspects in the process of case formulation. So not only the AOD and mental health issues, but also their social cultural factors, motivation, living situation, and medical and personal history. And in addition to mental health services, health workers may need to engage with a range of other services to meet clients' needs, so including housing, employment, education, training, community justice, and other support services. And just to emphasise that it's so important, given the range of presenting issues, to treat the person and not just the illness, or not the illness. So I just wanted to thank you all so much for having joined us for this webinar. And if you're interested in viewing this or other webinar recordings, these can be viewed via the CREMS website. And to complete the CPD assessment attached to this webinar, you can click on the link on this slide and remember to submit your responses. You can also join us in the next webinars. So on the 21st of November, we'll be discussing the management and treatment of comorbidity. And on the 5th of December, the final webinar in this series will focus on the management of physical health of people with comorbidity. And more webinar topics will be covered throughout the CREMS webinar series. And if you're interested in any of these, you can subscribe to our mailing list. You can also contact me on that email address if you have anything that I've not covered or anything you would like to feedback. Thank you.
Thanks, Chris. I'm not sure. Can you see me on the video at all?
Yes, I can.
Okay, I can't see myself, but that's all right. Great, thank you so much. We do have a few questions that we'll try and get through quickly in the few minutes that we've got left. But also, if people do have questions, please feel free to keep posting them. And any that you have afterwards, as Chris said, please do feel free to get in touch. Firstly, I was just wondering, you mentioned how important it was for clinicians to be familiar with the symptoms of the different disorders and to be able to do the identification process. Where could people go to sort of get more familiar with the symptoms of disorders?
That's a good question. So they can go to the comorbidity guidelines that I mentioned. Mm-hmm. I had the link for where you could access the PDF at the beginning. I think it was on the first or second slide, the beginning of the talk. And it has quite a good overview of some of the conditions that commonly co-occur with substance use. But if anyone would like, if you're feeling quite ambitious and you'd like further information across a broader range of disorders, you can look at the DSM-5 or the Diagnostic and Statistical Manual of Mental Disorders, currently in its 5th revision, and you can access that, or that's published by the American Psychiatric Association, and you can access that online, I think.
Yeah, and I think there's some nice summaries as well online, even if you can't access the DSM itself. But
there's some good case studies too if you manage to get into the DSM-5. Much better than what I've talked through. Much more detail.
And just how important is it, do you think, that have the diagnostic label?
For the client, I think it could go either way. I think some people might find a diagnosis, as I guess a bit of a barrier to progressing throughout treatment if they're being labelled as something, given a disorder. I think other people might find it, might feel intense relief or release, I guess, if they're given, if their symptoms are normalised and validated. And I guess this would really be up to their healthcare worker or practitioner to decide how, or, to get a sense of how their client is likely to react within the bounds of their therapeutic relationship. And I guess for the clinician, a label of a disorder is can be really helpful in terms of knowing how to communicate with other services, where to find additional information, and how to liaise, which services to liaise with can be quite helpful.
Yep, no, definitely, yeah. And I guess essentially you're always sort of treating what the person presents with, like you said, that sort of complex array. But a diagnosis can be sometimes helpful in directing what treatment responses might be most effective, depending on that presentation.
Yeah.
You know. And just last question, I wanted to ask you about the, or if you could comment on the role of family, friends and carers in the identification process.
Yeah, I think, that's also really important. Family, friends and carers can be really helpful and really important in terms of providing a different perspective to what the client or the patient might be giving, and, in a sense, filling in some of the gaps. But it's so important to get the client's consent before involving, their permission before involving families, carers or friends in treatment or assessment screening process.
Great, absolutely, thanks. Do have more questions, but we have run out of time. Thank you so much, Chris, for that presentation. It was wonderful. And again, everyone, the slides and handouts will be available for download from the website after tonight. We'll put those up tonight. And we can also email those if you wanted them sent to you directly. And please look forward to seeing you at the next webinar on managing and treating co-occurring disorders, which will be on the 21st of November. Thanks, Chris.
Thank you.